All right, great. We always have some people continuing to come in online and in person, but we'll get started since we have a lot of interesting and valuable things to hear from our esteemed guest. So it's my great pleasure to introduce Wanza Mbole, who is also one of our lead fellows for the year. You all probably heard me say already that GHP jointly hosts with the Harvard Global Health Institute a cohort of just a few very distinguished lead fellows every year, and we are honored to hear from them. And you've already met Cindy, who presented last week, and you'll meet Dr. Julika, who will present next week. And so, yes, so I'll just read a brief bio. We'll get started. I'll give you a little heads up while we're running out of time, and then we're welcome questions from you. Are you okay to people ask questions for clarifications? Yeah.
I think we could do that. I assume
But bigger
what
questions
matters
for
is that
later?
at the end of the day,
Yeah.
at the end of it all, we get to use
Okay,
so we could take it whichever way makes sense for people.
excellent, thank you.
Yeah.
Okay, so Wanza has worn many hats. She's a health finance specialist in Kenya. She leads on building an inclusive national financial system, enabling households to build resilience to economic shocks related to health. She is particularly passionate about enhancing women's and low-income households' resilience in Kenya, where out-of-pocket expenditure has consistently accounted for at least 25% of the total health budget. She currently works for FSD Kenya, a nonprofit organization supporting the government on inclusive finance policy and the industry to design appropriate financial solutions. A key input to this work is research. So Wanza is leading research on women's and households' health needs, healthcare seeking behavior and access, health financing and other coping mechanisms, and opportunity costs, and using the insights from this research to inform health finance. Obviously, her work fits right in with the interests of this department and the school, so I will let her take it away. Thank you for joining me. Oh, sorry, I have to also say that our speakers have been invited to share their personal perspectives, and they do not speak for Harvard.
So thanks very much, Jessica, and thanks for having me. I feel honored to be here. It's a real privilege for me to be sharing, share some insights about what we're doing back home in Kenya. Just to mention, I work for FSD Kenya, and as Jessica read from FSD Kenya supports both the health finance policy. It supports financial inclusion, as we see it. And we support the policy and working in partnership with the government and its various departments and agencies. And on the other side, we work with the industry to ensure that the appropriate financial solutions to deal with the areas that households are living. And so I'm leading the work on health finance, as she's indicated. So I thought of sharing our experience in relation to using social or national health insurance as a means to universal health coverage. And just to mention that everything I'm going to say today involves many other people. I'm not an expert in all the things that I'm going to say, but I welcome your open views because this is very much work in progress. We continue to try and figure out how best to track the impacts of the universal health, the social health insurance on delivering universal health coverage. So just for context, we gained independence from the British in 1963 and inherited a British sort of constitution from them, which we used for many years until 2010, when that was, I would say, I don't know whether to use repealed or overhauled, but yeah, it was changed and quite significantly. And one of the things that did for health was that it made health, access to health a fundamental right for every Kenyan. And in 2008, and the timelines there start to look a bit interesting because the president we got then was already starting to think about what's the steer for the nation. He was an economist and was quite clear on the legacy he wanted to create for to leave behind. And so he had started to think about a vision 2030 around 2006, 2007. So when he came into office and with the work on the new constitution going on, he made universal health coverage central to that vision. And the vision states that the government was to provide equitable, affordable, and quality healthcare to all citizens, which in a way ended up being reflected in the final constitution. And so with that came the devolution of power to the 47 counties that we have. I wouldn't call it a rural government, but it's something similar to that, where we have governors. I don't know where we borrowed that from, it's relatively young. But yes, with that sort of system, governance system in place. And fortunately or unfortunately, healthcare delivery is one of the more functions. As to what that means, we can dwell into it a little bit more, but basically the national government employs the personnel, or most of the key personnel that think through the policy at the national level, and the county governments have to look into how that is financed and the delivery, especially delivery of primary healthcare. And so moving on to other bits, currently there are 58 million Kenyans in existence, and we are pretty young nation, I say. Our median age is 20 years as I speak, and we are growing old pretty fast. A couple of years ago, just about 19, and that says a lot in relation to the health needs and what needs to be done. I don't want to get into that, but like for us, reproductive health is it's a big issue, and the typical issues that go with that. And so 70% of that population is rural, and 85% of them are in the informal economy that gets repeated down there. And that informal economy only contributes about 30% to our GDP, meaning that 15% who are employed in the formal sector sort of have much more than what the 85% have. It doesn't directly translate to that, but we'll be running into that over and over again, especially as we talk about Wanza insurance and why they are insurance and the others don't. And 40% of the population lives below the poverty line. I didn't do a good job converting those numbers into dollars. But I think the first one would come to something like $33 per month. I did the second one. You can double that to get just a rough idea of what that is. And we have some notable inequality within the population. So for background, the majority of Kenyans are not insured. And this has been the case right from the beginning. And as early as 1966, there was a thinking around minimizing the cost of providing healthcare, especially inpatient care or hospitalization. So the National Health Insurance Fund was calling it National Health Insurance Fund. Those days it was a National Hospital Insurance Fund. It was established to just help manage the cost of hospitalization for those who are in formal employment. And the situation has always been more or less what I've already shared. And so, but in 1972, its mandate was extended to cover volunteer contributors, and anybody who contributed to NHIF got access to similar benefits. And the beauty was, with NHIF, the volunteer contributors only contributed the minimum. Even there's change started to happen, and there was some sort of graduation of contributions, especially in recent years. For always contributed the minimum in Kenya shillings 500. And so that was the fund was renamed in 2022 to the National Health Insurance Fund, and the aim of that was to make it cater for much more than just hospitalization, to open it up to provision of or to catering for provision of healthcare services, such as diagnostics and others that were not part of its initial, within its initial cover. And with that also came opening it up to a wider range of healthcare providers, like those who are doing diagnostics, and we are starting to see some bit of pharmacies and others being brought under that umbrella. And the thinking even then was that NHIF would be used to deliver UHC in Kenya. Then in 2023, the government started thinking about a social health insurance fund, or social health insurance as a means for universal health coverage. And that thought finally translated into a social health insurance policy, whose implementation started last year. But before we even got there, the previous administration in 2018 introduced some universal health coverage pilots in 4 counties. And under those pilots, what happened was that the county governments fully subsidized the contributions towards the premiums with the National Health Insurance Fund. And the truth is, in as much as everybody was covered, the story we hear is households got the card, but not everybody knew they had covered. So they still continued, some still continue to pay out of pocket. And it's only one particular county where that seems to have worked better. And I think there was a lot of awareness creation around what the cover meant. And the results were interesting, but in these other counties, the status quo remains. So based on those pilots, the government started thinking about rolling out UHC using social health insurance. And that's what got us to the new policy that we have in place, whose implementation started in October last year. According to the new social health insurance policy, every adult Kenyan is supposed to contribute 2.75% of their gross income towards the social health insurance fund. And the promise is that that would enable us to all access all sorts of care, both primary and secondary. And so when this policy came into being, myself and the team I'm leading started thinking about what that means for health finance, the ability to access an appropriate solution, or the ability to have in place an appropriate health finance solution that can help households deal with their health-related economic shocks. And so we partnered with the Kenya National Bureau of Statistics, and that has been an ongoing partner, especially in relation to national surveys, and designed a health finance tracker. And our thinking was that because despite the engagement with various stakeholders and views that the policy wasn't likely to make a difference as package, the government, the administration was keen to have it in place. And it became a bit of a sensitive issue. So it was launched regardless of the views that the stakeholders had. And so we thought, given that the ship has sailed, we can't just let it run into headwinds. We have to do something because it's what we exist to do. And we came together and put together the health finance trackers survey because we wanted to, and we borrowed a lot from other related surveys, tracker surveys that we've done as FSD Kenya. And so we wanted to monitor the impact of the policy on Kenya's ability to access healthcare and the economic impact of that too, like out of pocket expenditure. And so for this, because we were trying to see whether we can come up with something that was nationally representative, we decided to leverage the FinAccess data. FinAccess is financial access survey that happens every 2 or 3 years in the country. And part of that is health finance. So we thought we could start by looking at the questions we have in the survey that are relevant to health and build on to those to get a better understanding of what was going on as a baseline. And just to speak to the limitations as I get to share the data, the one thing that turned out to be a real limitation was we were trying to do this fast and we made it a telephonic survey, or we used telephonic interviews, and we could only reach out to those who had been part of the FinAccess 2021 survey who said they could be. We could reach out to them for subsequent surveys. So that reduced the number somewhat, and it also brought in the issue of only being able to reach out to those who had phones, because we still have a few Kenyans who don't have phones. And the other thing that's typical in Kenya is the number I'm using today, the phone number I'm using today might not be a number I'm using tomorrow. You could call me and find that the number is with someone else. So if you sample, you start by picking the population of those who said, yeah, you can reach out to me. You can reach out to me in future for similar studies. And then within that, you also find there is an issue. Yeah, you called my number, but it's not me anymore. So all that. And we also decided to have a sample to ensure that those with insurance were represented. So, and then coincidentally, the last FinAccess survey was undertaken towards the end of last year, just around the same time. And so we decided to use that to complement and triangulate what you got out of the tracker survey and the samples as indicated. I think I've touched on these, I won't dwell on it much. So the way we analyzed, so the way we analyzed the findings from the tracker survey and the FinAccess data is as shown. And so we're looking, I'm looking at insurance coverage and also the value of that insurance. Like, is the coverage, how is the coverage in a broad sense? What's the overall coverage, and how does that look like for the various demographics, like within the 5 wealth quintiles, and also in relation to value, the extent to which the coverage or the cover is able to deliver quality healthcare and financial economic benefits to the households, such as minimizing out-of-pocket expenditure. So again, as indicated, health insurance coverage in Kenya has always been quite low. This is what it looks like for the National Health Insurance Fund. Well, I'm ignoring the private insurance a little because it's minimum. I think it's 1.something%. And the focus of the social health insurance policy is not the private, it's the national health insurance or the equivalent of the same. And I'm using the national health insurance because we didn't have the social health insurance fund before late last year. And we are trying to build the foundation or a baseline to use in monitoring the impacts of things. So the numbers there show what the trend has been. It was highest in 2019 before COVID. And we're hoping that by 2024, we'll start to see a recovery, which unfortunately didn't happen. And we suspect that there is a lot of the shift of the new social health insurance policy noise around the numbers or impact around the 19.4% that we are seeing there. Because when they start talking about it and making it compulsory, and there were challenges already in accessing services, even for those who are contributing, then people stopped contributing to it, especially those who are making voluntary contributions. And as you can see from the little table up there, for the formal sector or for those formally employed, the retention rates have been relatively okay, because it's mandatory for us to contribute towards the National Health Insurance Fund, and it is for us to contribute towards SHIF. But the real challenge lies here. And what happens is that you find that those who are buying the National Health Insurance, or those who are covered, or those who are making the contributions, were doing so because they needed it. So there was a lot of adverse selection and so forth, but at least it was still making a difference in households' ability to access healthcare. So in addition, NHIF usage had consistently been concentrated among higher wealth quintiles and, again, as already said, employed. And so this is what I'm doing a bad job using the pointer, but the right hand side of this shows what the usage of NHIF looked like within the wealth quintiles, and clearly the highest wealth quintile being those who are covered by it. The trend makes sense given the economic situation. And before the new social health insurance policy was put in place, we're starting to see some traction in relation to the retention rate, the light blue color. At least people were renewing their NHIF accounts or making contributions, meaning that it was delivering some value. But affordability was still the biggest barrier to uptake and use of NHIF, as indicated by the bars at the far left there. So dwelling a little bit on the affordability, as you can see, the premiums were never much. 500 shillings would be about $3, $3 or $4. And that is what those in the informal sector are supposed to contribute towards a National Health Insurance Fund per month. And at this point, it had become a bit graduated for those of us who are in the formal sector. So some were, if you are earning more, you're contributing more than those who are earning less, but the floor was at 500. But even with that, Kenyans were struggling to make their monthly contributions. And only about a quarter of Kenyans had the National Health Insurance cover. When it comes to value, most Kenyans perceived NHIF to deliver value. And this was the case among both the covered and the uncovered. So like when we talk to those who didn't have the cover, they would say, yeah, I would like to have NHIF. I know it's done this and this for others. And they could point to many positive examples. But the barrier was always affordability. And so all this is a background to what that means for SHIF. And so even before the new social health insurance policy was put in place, people went without healthcare, and quite a significant number of proportion of Kenyans went without healthcare. The figure on the chart on the left is a global picture, and you can see the trend between 2019 and 2024. we understand the 2021 numbers. That was a COVID period. And so I would say I was so looking forward to see what would come out of last year's numbers. They were slightly better, but I expected them to be at least as good as was the case in 2019. But that's what it is. 44% went without care. And when you look into the impact within the wealth quintiles, you can see that it's mostly those in the bottom two wealth quintiles, where that is 60%, the other two are below the 44% overall figure there. And the reason for going without healthcare was not poor accessibility of healthcare facilities. It was basically an affordability issue, as indicated there, where lack of money accounted for, among the rural particularly, accounted for close to 60% of the reason for going without care. This particular chart came out of analysis of the health tracker survey data. It's busy, but I'll give you a second to take it in. But what's clear from it is that having health insurance minimized foregoing care and other health then related economic shocks. So when we're looking at, when we're analyzing the data, and I didn't do it myself, I'm speaking on behalf of my team, we control for two things. One of them was formal employment and the level of education, because those two are quite closely related. And if you look at the ability to, the impact, the aspect of foregoing care, it's clear that those who didn't have any health insurance, mainly with NHIF, ended up foregoing care much more than those who had NHIF. The same goes for the health condition worsening while waiting for money. It was more of a factor for those who didn't have cover compared to those who had insurance cover. And so was the case with financial strain, paying for healthcare and using adverse coping strategies to pay for health. And those included things like selling basic assets, mostly household assets for lower income, including the lower income quintiles, wealth quintiles. So it's obvious that even with, from this chart, that even with NHIF, Kenyans still spend out of pocket. Meaning that NHIF was not a perfect solution. It catered for some things, and particularly the high expenditure health events like being hospitalized or needing to go for a major diagnostic, or things like a treatment for chronic illnesses like dialysis and so forth. But people still spend out of pocket, especially in relation to outpatient care. That's what the picture looks like based on the FinAccess 2024 data. I found it a bit of a mixed story. It would have been nice to see, especially for the wealth quintiles, a trend, a nice something. But this is such a mixed message. When you get 1,000 for the lowest wealth quintile, and 1,000 for the highest, what do you do with that? And we are starting to look into that, and I think it will take a lot more analysis and qualitative analysis to understand what's going on there. Because and the interesting bit is the highest wealth quintile has health insurance, some from the private sector, which provides a comprehensive outpatient care. And the ones in the lowest wealth quintile are not likely to have that at all. Yet they are all spending out of pocket. And the stories you hear are a bit mixed. But yes, and I think the bigger question is, does the 1,000 for the lowest wealth quintile, that median, have same weight as the 1,000 for the highest wealth quintile? And the answer is no. And particularly when we get back to the data I started off with, that our poverty line is about 4,300. So if someone just either below the poverty line or just above the poverty line has to spend 1,000 shillings out of pocket to access healthcare, what does that mean? It will probably start to drive that sort of a household into catastrophic health expenditure. This similarly came out of the analysis of the Health Finance Tracker Survey, and whereas what this shows is that having health insurance appears to have reduced out-of-pocket spending on hospitalization specifically, although the results are not statistically significant. So what does this mean for the social health insurance policy or fund and the universal health coverage? And what we saw, or what we got from the Health Finance Tracker Survey is that the costs are shifting. They're shifting in ways that are not entirely clear, at least to us for now, but the ability and willingness to pay are likely to remain significant challenges for Kenyans. And the question we asked in relation to this, because this was before October 2024, when the social health insurance policy was effective, the question was, based on the promises that were being made and so forth, if you were to access all the healthcare you needed, how much would you be willing and able to pay for it? There's nothing magical about where that the discussion is, but what that says is that 70% of Kenyans are willing to pay only 2,800 or shillings or $20 per year or less to access health cover, which is below the bare minimum that's stipulated for the social health insurance fund. And that is on the promise that they would never need to spend a shilling out of pocket to access healthcare, which is not the case, was not been the case in the 6 or so months since the policy was effective.
But that 5 months.
Okay, I'll include the rest. And so the other bit to it is that we looked into whether, as stipulated, the social health insurance policy is likely to deliver care to Kenyans. And the primary health care is supposed to be delivered through their community health promoters and the village dispensaries. And so the question we asked was, do you know your community health promoter? And particularly those in the rural areas seem to know their village health promoters. But the one thing that was obvious was they didn't have as much faith in the local dispensaries and the community health promoters to meet their health care needs. So what does this mean? Not there, but yes. So the current status in relation to SHIF, based on these, is that there is an intention of SHIF is universal coverage. 19 million Kenyans have registered on SHIF, but only those who are formally employed and mandated to contribute are contributing to about 3.7 million. And it's been hard to collect premiums, especially from the informal sector, because they don't have visibility of their incomes. They don't know how to tap into those incomes. The aim is to use means testing to determine who is getting what amount of income, so as to determine what they can contribute. There is a promise, and I hope genuineness in saying that the government will cater for those who are not able to make any contribution at all. The minimum 300 shillings per month, but it's not obvious how that will happen, and it's a real challenge. It's what we hear every time when those involved get to talk about it. On the values side, only 20% of Kenyans were covered or had health insurance, and the benefits of the social health insurance fund currently are not as comprehensive as NHIF or what we had previously. And so that's likely to lead to more out-of-pocket expenditure, especially for lower wealth quintiles. So in conclusion, we had a solution in place in form of the National Health Insurance Fund. It was an imperfect system, as already indicated. It was delivering what it was delivering for those who are able to pay. And I should have mentioned here that the government was subsidizing premiums for some vulnerable demographics, like the elderly, who have some social protection, and the orphaned and vulnerable children. And that number, the number under that program had increased to about 3 million. It depends on where you find the data. In the few years since the implementation started. So there is a possibility that the government will contribute something for the vulnerable households, but that was happening. And so in addition, affordability was an issue, and it will remain an issue. And so as we start to look at the implications for the social health insurance policy, we know the proposed rates are not affordable to Kenyans, and it's punitive, particularly for those in informal employment, because it's not delivering the minimum of healthcare. So what's happening for those who can afford is you contribute because you're mandated to contribute to it. It's deducted from the salary. I wish everybody else is not deducted this month. Let's talk about it. It's deducted, but you still go to arrange for private health insurance for those who can afford it. What's happening to some is that, like if you're working in a smaller organization or smaller business, it's your employer. It's deducted from you, it's remitted to shift. And that's all you get because you can't afford anything more. And so that will continue to be a challenge as to how to determine the amount of premiums that households should contribute and how to collect them for the informal sector. That's a big challenge. And I don't think there are easy workarounds. And chances are that it's going to increase the out-of-pocket expenditure and reduce accessibility to care. So for me and my team, our aim is to continue to monitor the impacts of the policy on Kenyans' ability to access quality healthcare and out-of-pocket expenditure, and use what comes out of the tracking to provide evidence-based policy recommendations and hope that we'll end up with something better. If that means reverting to an NHIF sort of solution.
Thank you so much for your presentation. Start with questions within the room.
Thank you so much, very interesting. I was wondering, your survey was nested within the other survey, which had like 28,000 responses. Could there be ways you mentioned you have weighted it for insurance only, but age, sex, other characteristics, employment, it could have been a much more, I guess, extensive weighting that goes back to the census possibly and sort of makes it nationally representative. I wasn't sure what that was done.
Yes, so I didn't get to share. I should have found the figure for the FinAccess 2021 sample. So the tracker survey was undertaken around we did that around mid last year, June, July last year. And the 2024 FinAccess survey happened in September. The data collection was September, October last year. So there's a lot more in the data that one can come up with, but given the smallness of the sample, we didn't start to look into things like age and other aspects of the demographics we dealt with the results. We thought it would start to use meaning reports that are granular. So for that, we didn't do that. But on the aspects that relate to finances, yeah, it's possible to get to see who has insurance in relation to gender. Just to mention, when you're talking about a 21% access to insurance or health insurance coverage overall, but when you get down to the gender aspects, for men that's 25%, for women it's 16%. So those start to become visible quite quickly, and the same goes for you. When you're talking about financial inclusion of whatever kind, whether health or something there, or maybe access to credit, you find that the youth, especially between 18 and 25, have the most coverage for obvious reasons, because they don't have the economic power to be included.
I'll let you call on people.
Yeah, thank you for the talk. I think you mentioned in the previous UHC pilot, the pilot that was conducted before the current administration, it sounded like based on what you were describing, essentially the government paid the premiums for everybody. And then when the new government came in and they passed the legislation, it's much more of a social health insurance model. And the social health insurance model, that challenges that you're describing, challenges that many countries have had. So do you think it was the new president having a different idea of how to do UHC, or was it financial pressures, or what led to those changes?
It's a typical case of when you pilot in one context and you want to scale in a different one, because that was only in 4 counties. So, and I want to believe the resources were available for doing that, subsidizing of premiums for everyone in 4 counties. And that was taken on by the national government, but it made some contribution towards it. So when it comes to covering 47, the competing priorities start to play out. Do you pay for health insurance and probably invest nothing in education or something else, which is probably a more important priority? And I think that's a challenge that we're dealing with, not to mention that we've a huge public debt issue. So even as you start to think of what recommendations you can make, you have that in the back of your mind. You say, okay, it's not making sense. Can the government pay for those earning these and below from the national kitty? And you know their competing priorities. And I think that's a real challenge that wasn't sustained. And as to why we still before trying to see whether these counties they pay for themselves, or the counties will make for themselves. And it could be be a political issue because, yeah, we have 47 counties, and it was only pilot.
Thank you for your presentation. I was just wondering, as Kenya's trying to roll out like SHI, how would that fit in with current social programs like Linda Mama? Like, would there be a certain coverage rate in which you would want to scale back Linda Mama, or like are there cases where they would overlap and like there'd be issues with reimbursement?
Thanks for that, and let you know about Linda Mama. So when the social health insurance policy was put in place, it was supposed to deliver, to every Kenyan. And the first thing was done was Linda Mama was stopped. The also the other thing that ceased was our health NHIS that was provided to students. And so there was a lot of outcry in relation to Linda Mama particularly. And the position is not obvious. It's not that it's back as a subsidized program, but it wasn't back of our social health insurance program. It had been stopped. I might have lost touch a little. It could be back. But yeah,
In the last
but
2
March
weeks.
it wasn't happening. Yes.
I just had a question on the benefit packages. You said that they were shrunk after a bit, like if you compared the shift package relative to the NHIF package. And I'm curious if you could talk about what things were kind of included. I presume it sounded like more of a shift towards some of the preventative and primary healthcare. So, what things were removed, like some of the, I guess, the inpatient services, and how do you see maybe that package continuing to change with the recent like USG and PEPFAR cuts?
Thanks for the question. I'm likely to get there. I don't have the figures top of my mind, but the current rates will be an example. Obvious. I'll pick on chronic care. It's managing diabetes. So the cover for the year, the benefit for the year is something like 3,000 Kenya shillings. What does that translate to in dollars?
250.
It's pretty. It's like 250. It's very little. Maybe 2.5.
Maybe like 20 to 25.
Yeah, it's very little. If you walk into a private healthcare facility to just check your blood sugar level, that the test, it will most likely take either the whole amount, 1 visit, the whole amount, or 2/3 of that annual. So that's the sort of space we are in. Those who are using NHIF were able to access as much care as within the limits they would access care, and probably it wasn't viable. And yeah, so the limits are quite small. And the other thing that happened, apologies for zeroing the reproductive health bit, is that SHIF, for instance, does it cover reproductive health? If you are below 18 years and you get a child, you take care of yourself. So we Linda Mama catered for every mother. But if you're below 18 years, she does not take care of your maternal health and many other things like that. So, but the limits are small, and so it's a real challenge. And so for us is to keep monitoring what's happening to Kenyans' ability to access healthcare, what they're spending out of pocket, and keep engaging those in charge of the health policy to to see whether we can have a change. And in addition to this, or in prior to this, we carrying out what we're referring to. Does anyone know about use of diaries as research tool? Diaries, where you select households and work with them for a period of time, capturing all data related to the topics that you want to understand. So we are doing a healthcare financial diaries research across 6 counties, which represent 47. We're starting now and we'll be for about 2 years, so that will give us an idea of what's happening from to generate evidence to nudge that policy in the right direction. I'm hoping it's nudging, not shoving.
Thank you, Wanza, for the presentation. Just a quick comment on what you said. I would have thought doing the diaries should have come before changing the policy. At least you're doing it now. But I wanted to ask, so Sierra Leone were also considering changing the insurance policy, and there are mixed feelings about this. It's one school of thought, there in the language things it's going to. And then I wanted to ask you this. I think I know what you're going to do, but I'll still ask. Because I think we're even in a worse off situation in terms of very small, we have more people in the farming sector, so we have similar problems. And then I also don't know about how much people are seeing the value of our opportunities. If I was to ask you, should we go say yes or should we say no at this point? What would be your candidate?
Question, Julie.
And it stays in this room, I promise.
You know, at least you're in a position to say yes or no. As Deputy Minister for Health. So I don't know of any. I don't know of any place in that sort of context. An informal economy. Where social health insurance, that's what I don't think it can work. And I was privileged to talk to the whoever is behind this, in the executive, and it's borrowed heavily from UK's so different. I mean, economics can be any more different than that. And I don't know. I don't think it will work. And so for me, it's the biggest thing I aim to do with the research is to make it obvious that this is not working for me to make it work. And I want to be surprised. I want to hear that can work, but I don't think it will work. And at times I almost wish that it can fail fast.
So you
Before it ranks economic outcome. And yeah, if it fail completely today, wouldn't we start to think about a solution tomorrow? But it's probably something that comes. I think there is a whole coming from this question. It can work.
Yeah, thank you so much for a great presentation. I was very interested in also this informality, right, which is presupposed in these kind of systems in other countries. And I was just thinking both about the informality in terms of workers, but also in terms of the healthcare system and sort of different sort of, let's say, type of healthcare providers. And I was wondering if you could maybe expand a bit on that, sort of that, what are you getting access to? And if you ask someone who has not experienced access to, let's say, like Western medicine or hospitals, how can they set it sort of a value to something they don't have a relation to in a sense, if that makes sense.
Another question, so. The Kenyan health financial, sorry, the Kenyan health system is it's diversified, I would say, but it's also unique in that when if you're living in rural Kenya, where about 70% of the population is, the household or individual economic power is and so you don't find much of the private sector there. If you're talking about the healthcare facilities, I'm not on the pharmacies or health providers. We've split over, it's split 54% private sector and 46% public sector. In the rural areas, most of the providers there are public sector. And that poses a challenge in that, you equipment, and every other thing that you can imagine. So, and the foregoing care, I didn't get to who forgoes care, actually, that would be an interesting, because if you're in the rural, if you're in rural Kenya, it doesn't last that you don't have much of an amenity. Even if it's right out of pocket. There might not be a private health clinic near you where you can walk in and access quality care. You might have to travel far out of where you live to access a private facility, because economics of the business case, you don't have to be there for that facility to exist. So that's us. If you go to a private health facility, chances are that you get all the care you can afford. If you go to a public health facility, and your stories for going here will be things like, why go? Pay attention. The facility, nearest to the public healthcare facility. I don't know whether that answers your question. I don't know, it gives you a bit of an idea.
So I know we still have many questions and we also have some on the chat, but we're over time. So let's just thank you very much for. And thank you all for coming. Have a good day.